Good afternoon, everybody. I'm Lucy Abraham. I'm an HUR scientist at Pfizer. And today we'll be taking you through a Pfizer Lilly industry case study looking at patient preferences in chronic pain. Just to remind everybody, this webinar is recorded and it will be made public afterwards, and any questions or personal information will be removed before we publish that. Just a quick disclaimer, this study was funded by Pfizer and Eli Lilly, and the presentation of its contents reflects the views of the presenters. Just also a few acknowledgements to our colleagues, our vendors and external consultants that contributed towards this study. There'll also be a Q&A at the end of the presentations. Please feel free to submit your questions in the chat during the presentations. When we get to the Q&A, please remember to unmute and please do speak up. And if you have any questions after the webinar, then please contact the Prefer Consortium via the email at the bottom of the slide. Okay, I'll just take you briefly through the agenda for today's presentation. I will give a brief introduction. That will be followed by Brett Hauber, who's a patient preference elicitation expert at Pfizer, although formerly was at RTI Health Solutions when we conducted this study. And he will give an overview of the study design and high-level results. Next, we'll have Marco Boeri from RTI Health Solutions. He's a senior research economist there, and he'll be taking us through the methodological findings, looking at differences by pain type, also looking at differences in rankings, whether you use the DCE or best worst scaling. And then we'll also look at impacts of locus of control on preferences. And then finishing up the session will be Kristin Bullok. She's a benefit risk management scientist at Eli Lilly, and she'll be taking us through a quantitative benefit risk evaluation utilizing the utilities generated by the preference study. And then we'll have a 15-minute session at the end for the Q&A. So in terms of the study rationale, over the last few years, there has been a growing emphasis on patient-centered care and how patient preferences influence compliance and acceptance of treatment recommendations. And increasingly, the assessment of patient preferences is important to both regulators, but also reimbursement decision makers. So there's really a need to understand patient preferences for treatment characteristics and the benefit risk trade-offs patients are willing to make. At the time of the study, Pfizer and Lilly were evaluating an investigational nerve growth factor inhibitor, or an NGFI, for the treatment of chronic pain associated with moderate to severe osteoarthritis, or OA, and chronic low back pain, CLBP. NGFIs have a different mode of administration. They're subcutaneous rather than oral, and they also have a different side effect profile than the commonly used treatments for OA and chronic low back pain, which is typically NSAIDs and opioids. So in terms of primary objectives, this was to quantify patient preferences for pharmaceutical treatments for chronic moderate to severe OA pain and chronic lower back pain. And these needed to be relevant to patients and also differentiate NGFI attributes from those of NSAIDs and opioids. So our aim was to quantify the relative importance of each treatment attribute included in the study, and also the trade-offs. So for example, the maximum acceptable change in risk of a side effect for a given benefit that patients are willing to make. We also had some exploratory objectives. So we wanted to look at the differences in preferences by condition. So we had patients in there with OA only, chronic lower back pain only, or with both OA and chronic lower back pain. We also wanted to look at differences in rankings, depending on whether you're using the DCE or the best worst scaling. Then we wanted to evaluate the impact of locus of control. This was a preferred primary research question that we were exploring as part of the study. And then finally, to compare the benefit risk of different treatment options for moderate to severe OA while accounting for patient preference. So I'll now hand you over to Brett, who's going to give us an overview of the study design and high-level results.
Thank you, Lucy. If we can go to the next slide. So the study was conducted in both the US and the UK, and you're already aware of that, I guess, because Lucy had mentioned that we want to compare the differences across countries. That's one of the methodological questions that we chose to answer. It was an online survey, and it included two primary components related to preference elicitation. One was a discrete choice experiment, which was actually our primary preference elicitation method. We also included a case one best worst scaling, really to do two things. The first was to gather some information about preferences for a number of potential adverse events related to the different types of treatment that we just couldn't accommodate or fit into the DCE. The other was to do some comparisons between the DCE and the BWS. It was not a direct comparison in the sense that we didn't set up both experiments to answer exactly the same question, but we did create some overlap, which I'll show you in a bit, in order to do an indirect comparison. The population were people with self-reported chronic, moderate to severe osteoarthritis pain or chronic low back pain or both. And most importantly, they had to be refractory or unable to take current medications, meaning that they had tried greater than 3 classes of pain medication in the past 2 years, or for some reason they may be unable to take NSAIDs and had tried 2, or they may be unable to take NSAIDs and opioids and yet had tried another 1 or 2 types of medication. So actually in this survey, very interestingly, we had a litany of prior experience that we had to go through in order to establish eligibility. If we can go to the next slide, please. So we started out with qualitative work, actually, before we even developed the quantitative study. And we did a number of focus groups. And in those focus groups, we identified the attributes that were important to patients. Then we compared that to the attributes that differentiate these nerve growth factor inhibitors from the alternatives, namely NSAIDs and opioids. And what we were able to do is literally map from one into another. And you'll see here there's an expanded side effects number of rows, where in fact what we did was we took the general idea of side effects and looked at what would be considered a key side effect of each of the different classes of medications, and we'll show what those are in a moment. If we can go into the next slide. So we took the risks and side effects, and the primary ones for each category are for NSAID, stroke, heart attack, and bleeding ulcer. For the nerve growth factor inhibitors, it would be severe joint problems, something called rapidly progressive osteoarthritis, or tingling or burning sensations in the fingers and toes. And for opioid, there are 2 types of risks that came out. One are the actual adverse events related to the treatment, and then the other is the risk of addiction or dependence. And from the patient's point of view, those were separate types of issues where the risk of addiction or dependence was the primary one that patients were concerned about. So we can go to the next slide. So what we did in this case is we took a key risk from each of these categories. So it was actually a heart attack risk. Sorry, this is incorrect here for the DCE. For NSAIDs, it was severe joint problems for the nerve growth factor inhibitors, and physical dependence or addiction for the opioids. Those were the 3 that were included in the DCE, and those 3 and others were included in the best worst scaling. So that overlap that I mentioned is those 3 particular risks. So we can go into the next slide, please. These are the attributes and levels for the DCE, and I'm going to focus on the DCE for the remainder of my part of this presentation, and then Marco will talk a little bit more about the best worst scaling when we compare the 2. So in the DCE, we had an efficacy attribute, which included both pain and function, as measured by the patient global impression, or patient global assessment, I should say. We had the incremental treatment-related risk of severe joint problems, which was the NGF inhibitor associated risk, the incremental treatment-related risk of heart attack, which was the NSAID associated risk, and the treatment-related risk of physical dependency, which was the opioid-related risk. We had the mode and frequency of administration. As Lucy mentioned previously, there was a difference in how the NGF inhibitors are administered, which is subcutaneously. versus the NSAIDs and opioids, which are administered orally. And we included an out-of-pocket cost with the scope test. You can go to the next slide, please. These are the best worst scaling items. And what we did is we included both the risk of each harm or adverse event, meaning the probability of occurrence. And those numbers were except for the 3 risks that are called out in green, were informed by consultation with clinicians. And then the risk for each of the 3 in green, those are the 3 that are in the DCE, represented the largest level of risk that was included in the DCE. So if we go to the next slide, please. So the DCE question is presented on the left, an example of that question. And you can see we used graphics for most of the items. And it was a forced choice between 2 hypothetical alternatives called medication A and medication B. There was no opt-out in this particular case. And then the example of the BWS question included 3 risks simultaneously, where people were asked which was most important and least important to avoid. And as in both of these types of methods, these are repeated questions according to an experimental design. Go to the next slide, please. So the US characteristics, the mean age for OA and chronic low back pain, and for concurrent OA and chronic low back pain, and for the full sample, mirror generally what we would expect to see as the mean and median age of people with these conditions in the US. And if we go to the next slide, in the UK. So the samples are very similar. The age in the UK was a little bit younger than the mean and median age in the US. We go to the next slide. So the US preference weights show us basically the trade-offs that patients are willing to make, as well as the relative importance. And there are a couple of things I'd like to just point out while we are here. The range of costs, which went up to $110 per month, is about the most important attribute in the DCE, and it's comparable to essentially eliminating poor symptom control. So going from very poor symptom control to very good symptom control is about equal to $110 per month. So those are really sort of the first standouts that occur. The other thing I'd like to bring to your attention is we get a very big gain in utility when we go from poor symptom control to fair symptom control. That gain in utility decreases as we go from fair to good. And the marginal utility of going from good to very good is even smaller. They're all positive, but the utility gain from an improvement in pain decreases as the baseline pain from which we are moving, or the baseline symptom control from which we are moving, improves. The next thing to point out here is that the treatment-related risk of physical dependency is very important. Now, that's a very high range for the treatment-related risk of physical dependency. It really depends on the sources that you look at, and Kristin will talk about this a little bit more, what the actual rate is. It's actually pretty difficult to determine, but the risk of avoiding the risk of physical dependency is very, very important to patients. The incremental treatment-related risk of heart attack is relatively unimportant. It's not that it's unimportant at all, but it is relatively unimportant in this particular context. And the incremental treatment-related risk of severe joint problems there seems to be some sort of threshold effect going on here, meaning that when we are going from no risk to a 0.5% of a risk, we don't see much disutility. And in fact, even though they're not statistically significantly different, the preference weights are disordered between no additional risk and 5 people out of 1,000 for this severe joint problems risk. Where we do see the disutility come is when we expand above the 0.5% risk and we get closer to a 4% risk. So then we can also note that mode and frequency of administration, which is oral twice a day, oral once a day, injection every 4 weeks, and injection every 8 weeks, seems to indicate that oral is probably preferred to injection. Oral pills once a day is probably the most preferred. And there's very little difference, or there was very little discrimination in the survey between injections every 4 weeks and injections every 8 weeks. You can go to the next slide, please. The pattern, actually, if you flip back to the previous one and then back to this one, you can see that the patterns are very similar between the US and the UK. And Marco will talk about the tests that, that we can do to see if there are differences. But generally speaking, the conclusions are similar between the two countries. So I won't spend time going through this graph in any detail. If we go to the next slide. These are just the relative importance weights where we've taken the difference between the most preferred level and the least preferred level and looked at the difference in utility. We scaled everything relative to the patient global assessment because that was the most important. And we eliminated cost here and focused primarily on the clinical outcomes. And you can see here that pain and symptom control is the most important, followed by the treatment-related risk of physical dependency. Mode and frequency of administration is actually nominally more important than the risk of treatment-related heart attack or the risk of treatment-related joint problems, even though those differences are not statistically significant. So we have those three things that fall toward the bottom and two things that rise toward the top. And those two things rising toward the top, again, are pain and symptom control and the avoidance of treatment-related physical dependency. If we go to the next slide, we can see pretty much the same thing for the UK. Again, not surprising because the preference weights were not very different. The relative importance conditional on the same levels is going to be very similar as well. So those are the primary results. If we go to the next slide, those are the primary results of the DCE and the best worst scaling. And really for this presentation, that's probably not as important as the things that are coming up. So Marco is now going to talk about the methodological findings, and then Kristin's going to talk about applying these weights to clinical data in a benefit risk evaluation. So I'll turn it over to Marco now.
Thank you, Brett. Yes, I was. Actually, it's interesting. It wasn't, but the software muted myself. Thank you, Brett, and thanks, Prefer, for organizing this webinar. As Brett mentioned, this study was conducted separately in the US and the UK, and we wanted to answer a few questions related to the methodological research question that where either the researcher, the study team was interested, or IMI Prefer pointed out as interesting methodological questions. If you go to the next slide, actually, yeah, the first, as mentioned in the agenda, I'm going to discuss differences in preference, differences across different type of pain or condition, as we talk, the pain caused by OA, by chronic lower osteoarthritis of the knee and hip, chronic lower back pain, and or both together. And we wanted to see whether these three groups had different preferences for outcome. And we looked at that in both countries. As Brett mentioned, the countries were very similar to each other. We could have used tests, Swaite and Louvier test, to see whether they could be pulled together, see if there were preferences or scale differences. I'm not going into that detail today, and I don't think there's much we need to prove as we'll see in the results. The preference were very similar. When we look at the differences by condition, in the DCE, and this slide shows the various p-values across the groups, we checked whether osteoarthritis was different from CLBP, osteoarthritis from both, and across CLBP and concurrent CLBP and osteoarthritis. We did not find any significant difference that is systematic across these groups. When I say difference is systematic, we tested it with a wall test, log-likelihood test. So you interact the subgroup and you assume them to be all, the interaction being all equal to 0. or not, and do a log likelihood test, and there was not significant difference across those. Well, if you go to the next slide, when we look at the UK, we did not find, again, any differences in the discrete choice, but we did find some differences in the best for scaling. And I'm going to show in the next slide what these differences were. If you go to the next slide, this is the only difference across the three groups that we found looking at the US and the UK. So in the US, there was no significant difference across. In the UK, we did not find anything in the best in the discrete choice, but we did find something in the best for scaling. And what we found was that responded with the chronic lower back pain appeared to be more adverse to having a stroke compared to the risk of heart attack than the other respondents responded with OA and responded with both OA and CLBP. Now, one thing that we need to remember is the difference in age. As Brett mentioned in his slide, people with CLBP in the UK were relatively younger to everybody else. So that could be a driver of this. However, we did not find that in the discrete choice. We only found that in the best for scaling. Now, this is relative importance rescaled, where everything is relative, in this case, to the risk of having a heart attack because of the medicine. Okay, so this is the comparison between the different conditions. Now, if we go to the next slide, we'll go and look at the next methodological research interest question, if you want, which was something that has been talked about, and whether we can use discrete choice and best for scaling and integrate the two findings and see whether they are different or not. Now, what we did here in the past, what was done was having the same attributes, same items in the two, and compare. Now, what we did, as Brad mentioned, is we included three of the risk, the three risk side effects that we had in the discrete choice, also in the best for scaling. So the incremental treatment risk of severe rapidly progressive joint problem, OA, the risk of heart attack, and the physical dependency were included in the discrete choice with different level, and the largest level was included in the best for scaling, which means that the relative importance of the discrete choice, which is the variation from the least importance, or the lowest level because they were ordered, to the highest level, should be comparable between the best for scaling and discrete choice. In the US, we found that the risk were in the same relative order. So the most important was physical dependencies, followed by heart attack, followed by the OA, the rapidly progressive OA. However, the relative magnitude was different. As you can see, the two bars of the heart attack and the physical dependency are larger in the best for scaling relatively to the risk of physical dependency. And so the relative magnitude here is different, but the order is the same. If you go to the next slide, we look at the UK, and here we find that, as Brett again mentioned, in the order in the UK for the three risks is the same. It's very similar. So a relative risk of physical dependence is the most important, followed by heart attack, followed by severe rapidly progressive OA. Now, that is in the discrete choice. In the best for scaling, things changed. They were not in the same order. So avoiding the risk of heart attack was statistically more important than avoiding physical dependency. So we see that the second, which was farther down, it was a quarter of the importance of the treatment-related risk of physical dependency. Now is more important in the best for scaling. We have this switch, and we didn't really go into trying to explaining why. The best for scaling captured that differently, and that's a research finding, empirical, that we can look more into. So this was the comparison between the best for scaling and the discrete choice. The next slide will summarize this very quickly, just for the record, since we will share the slides. The US were pretty much the same, but the relative magnitude was different. In the UK, we have difference across the relative ranking of the 3 risks between discrete choice and the best scaling. Let's go to the next slide. We look at our last methodological research question, which was focused on locus of control. Locus of control is one of the scaled identified by IMI as interesting to see whether they impact on preferences. We looked at by subgroups. We divided the sample in people with lower or higher than median locus of control in the 3 aspects of locus of control, which are internal control, chance, and powerful others. And we looked at whether those impacted on preferences. We looked at discrete choice, and in discrete choice, as you can see from the p-values, same tests run as before with the Wald test, log likelihood test. We did not find any systematic difference across the 3 groups. So apparently, the locus of control did not impact preferences as retrieved with the discrete choice experiment. Now, if we look at the best for scaling in both the UK and the US, we found p-values for all aspects being impacted, but all significant. So in the best for scaling is capturing something that the discrete choice wasn't capturing, and is capturing some of the risks are slightly orders different in the best of scaling, depending on whether the respondent had internal locus control higher or lower, internal chest locus control higher or lower than median, and power flow higher or lower than median. And if you go to the next slide very quickly, well, I'm going to summarize what are these differences for the US. For the US, essentially, who had higher internal locus of control was more risk averse to the risk of physical dependence and severe joint problems compared to risk of having a stroke. If you go to the next slide, we see that still in the US, higher chance locus of control. People who higher chance locus of control had a higher aversion for the risk of severe joint problems compared to having a stroke. While the third one, the next slide, powerful other, there was no real significant difference apart from qualitative difference across the relative importance. In the next slides, we look at the US, and we find that the UK, sorry, and we find that the next slide, we found that internal locus of control were very similar. So again, the discrete choice, the preferences from the discrete choice were very similar across groups, across US and UK. Even differences in preferences in the best of scaling were relatively different between UK and US. Earlier, we saw that in the US, locus of control impacted, and people with higher locus of control was more risk averse for physical dependence and joint problems. Here, we don't find that. They're very similar, these two subgroups. The next slide looks at chance, and we find that people with lower chance was less averse to physical dependency and rapidly progressive OA compared to the risk of heart attack than the others. And in the next slide, we look at powerful others locus of control, and we find that the risk of having a stroke was more important for people with a higher powerful other than the risk of heart attack, for example. So we found some nuances differences. And this concludes the exploration of the methodological aspects that we looked at. So if you go to the next slide, we go to the agenda and we pass to Kristin Bullok that talks about benefit risk management. Hi, Kristin.
Now I'm unmuted. Okay, I'm going to transition now from the patient preference study itself, but into how it can be used to inform a decision on benefit risk. But before I do that, just first, what is a benefit risk assessment? A benefit risk assessment fundamentally asks the question of whether the benefits, that is what one wants from a treatment, outweigh the risks, that is what one does not want from a treatment. A structured assessment puts these characteristics of the drug into the context of the medical condition, the need, and the treatment landscape. We as consumers do this, obviously, almost every day in our lives. And with respect to medicines, this could be when we take over-the-counter drugs, or if we have prescribed medications, whether we decide to take them or not. Other decision makers, particularly regulators, conduct this type of structured benefit risk assessment when they are reviewing a drug for approval or continued authorization. And here, often they just describe how they view the benefits and risks, again, using this, this 4-point structured assessment, and then coming up with their overall assessment and the statement on whether the benefit risk balance is positive. So for example, on the next slide, what could this look like? If you look at the little table on the upper left, consider treatment 1, which has a benefit of an 80% response rate. But then this is balanced by a major adverse cardiovascular event, or MACE, of 5%. So is this rate of MACE event, or the chance that you'll get a MACE event, acceptable? And then what if another treatment becomes available? So for treatment 2, where the response rate is a little bit less, so the efficacy is a little lower, but the risk is decreased by more than half. So which one would be more desirable, treatment 1 or treatment 2? Well, it could very well be dependent upon the person making the decision. Generally, we can conduct benefit risk assessments using just descriptive techniques and visualizations to help us understand the balance of these risks. But in a situation like this, it could be that with it being a little bit more complex, potentially one treatment not being more desirable than another, obviously, then we may want to do a quantitative assessment. And that's where we can directly incorporate the preferences or the desirability of the person making the decision or another decision maker into the benefit risk. And that's called a quantitative benefit risk assessment. And so essentially this is what we did. We took the patient preference study results. So what did the patients prefer? And we directly included that in our benefit risk assessment. So the rest of my talk will be on how we did this. So essentially on the next slide, our approach followed 4 main steps. The first being structuring the problem. So in other words, defining what are the medical products that we're comparing and identifying what characteristics, so the benefits and the risks of those treatments that we want to include in our assessment. And then the second step was measuring performance. So taking these clinical trial data for each characteristic, for each drug, and then assigning a number of how much that is worth. And then in the third step, we take this, the preferences that from the preference study, and we conduct the main analysis. So essentially so the W is the weight. And so we transfer the how much is important for each attribute from the patient perspective. And then we mathematically combine that with the worth for each data point across the treatment options. So in this figure, if you look at benefit A, you multiply these things as you go down from option 1, 2, and 3, and then as you go from left to right on the graph, these are simply summed up to come up with essentially the final step, which is the overall net benefit risk score and an overall ranking of each treatment option that incorporates the perspective of the stakeholder. So now moving into our specific quantitative benefit risk assessment work. So if you want to just quickly go to the next slide. For this QBR, we wanted to understand how the preferences of those with moderate to severe OA, so the same population as the preference study, inform the benefit risk comparison of 3 different treatment classes, and each of those treatment classes having a different risk profile. So then on slide 50, you will recognize the treatment classes as they are the same as already described for the preference study, and that is nerve growth factor inhibitor, which is an investigational treatment placed in the context of two commonly used treatment options for osteoarthritis, which is NSAIDs and opioids. Also, the treatment characteristics or the attributes shown on the left side of the table are ones already described before. So the beneficial characteristic is represented by PGA, Patient Global Assessment, for symptom improvement. And then there's a risk for each treatment class, as previously described. So RPOA is the severe joint problems, and then of course non-fatal myocardial infarction and dependence. So then what we do on the right is organize these data, combine them into an effects table, and then essentially conduct our analyses. So for those who are more technically oriented, you'll see that the main analysis is multi-criteria decision analysis. And then the other types of modeling that we used for sensitivity analyses are also shown in this diagram. And of course, I'll go into the data on this briefly too in the next slides. So the results. First, before I go into the results, just to quickly explain, a larger net benefit risk score means that it is a more desirable treatment option. And again, this is from the patient perspective, as we incorporated those, the patient perspective. You'll see that the nerve growth factor inhibitor has the highest net benefit risk score, but it's followed very closely by NSAIDs. The red bar represents the benefit, so that's symptom relief. And this is the major driver for all of the benefit risk scores. The main risk, that is driving the impact on the benefit risk score is dependence. So you see that with the bright green line. So because dependence is the most impactful to the benefit risk score, and on the next slide, the range of rates for opioid dependence varies widely in the literature. And so we conducted a sensitivity analysis. So basically asking, if this rate changes and by how much will this impact the overall ranking of these treatment alternatives? So in the left-hand graph, the red bar represents the nerve growth factor inhibitor. And then the brighter green line represents the opioids. From left to right, as the opioid dependence rate decreases, you can see that the ranking of opioids actually begins to approach that of the first ranked option, which is nerve growth factor inhibitor. So therefore, as we suspected, the rate of opioid actually can impact the ranking. The rate of opioid dependence can impact the ranking. So then on the next slide, a few other sensitivity analyses we conducted relate to data and inaccuracies or imprecision of that data. In this case, it is the preference weights, or what is the inaccuracy or imprecision around what patients said they wanted for different treatment attributes. And so we asked, how does this precision impact the ranking overall of the treatment alternatives? So the predicted choice probabilities analysis that we used here takes into account across all the attributes the probability or the likelihood that a patient chooses a particular treatment alternative. And so once these were done and combined together, we can see that the ranking essentially is the same, with nerve growth factor inhibitor being the highest, followed closely by NSAIDs. But what's interesting and helpful with this analysis is understanding the uncertainty, the error bars around these points. And we can see that there could be some overlap between the two classes of drugs for nerve growth factor inhibitor and NSAIDs, depending on the stated preferences. So finally, the next sensitivity analysis I'll show relates to the uncertainty, thank you, in the clinical data and all clinical data across the main impact to the main conclusion. And so this takes into account all the clinical data points. So as you imagine, we had a lot of clinical data points. And so it was really good with this sensitivity analysis is being able to assess the likelihood that each treatment option would be categorized into a specific rank. So for example, first looking at what is the likelihood they would be within a first treatment option or first rank, or a second rank, and so on up until we get to the likelihood that they would be the last option or the fifth rank. So on the left, the dark blue boxes represent the first ranked. And as you'll see, nerve growth factor inhibitor had the highest likelihood of being ranked first, with NSAIDs following closely behind. And then when we look at this, what I'm calling the medium blue bar, that is the second ranked option. So the likelihood that NSAIDs would be ranked second was similar to the likelihood that nerve growth factor inhibitor would be ranked second as well. So these overall, we say, are consistent with the main conclusion. And so then finally turning to the next slide and closing out the presentation portion of this webinar, the key messages we want to highlight are that assessment of patient preferences are increasingly important for regulators, reimbursement, and multiple other decision makers. The patient preference studies are one way to collect this information, and the one presented here for those with moderate to severe chronic pain demonstrated that the most important attributes were symptom control and then also avoiding the risk of physical dependency. When investigating the methodological research questions within the preference study, the findings suggest that the two methods used did not yield comparable results, but that the DCE data could be pooled across the two diseases, OA or CLBP, and across the two countries looked at, UK and US. Further, it showed that the locus of control didn't appear to predict preferences well. Finally, for the quantitative benefit risk assessment, we were able to demonstrate how we could effectively include the patient perspective using the patient preference data into our quantitative assessment and directly place those treatment alternatives into context from the patient perspective, even when these treatments had differing risk profiles. And so now I turn it over to Brett for moderating our question and answer session. Thank you.
Thanks, Kristin and Marco and Lucy for your presentations. We have a couple questions in the chat.